I just want to thank all of you for joining us for Teach Education Day, keynote address this year. This is the fourth Richard C. Vari, PhD, endowed lecture at the Virginia Tech Carilion School of Medicine. Many of you know this history, but it bears repeating. It really situates us in a place and in a mood that's appropriate for this event. In October 2021, when the toll of ALS made it too difficult for Dr. Vari to continue his work, we celebrated his career right here in this auditorium with tributes from his colleagues, students, and friends. In October 2021, when the toll of ALS made it too difficult for Dr. Vari to continue his work, we were here together. And at the end of the event, we announced the creation of the Richard C. Vari PhD Endowed Lecture to honor Dr. Vari's pivotal work as our founding Associate Dean for Medical Education. Rick was one of the earliest hires by our founding dean, Cinda Johnson. He was a key contributor to the innovative curriculum that differentiated us from the other new schools that were being launched around the same time. Rick passed away the following June, leaving a sense of loss for all who knew and loved him. And today we're very, very pleased that Rick's wife, Patty Vari, is here, and their daughter and son-in-law, Liz and Brock Mutchison. Thank you for being here today. Well, being in this space together again for the Vari lecture gives us a set of warm memories about Rick's life and legacy. One of the most memorable aspects of Rick's retirement event for me were the tributes from our students, faculty, staff, and colleagues from other institutions. In his own wonderful way of loving and supporting others, Rick Vari promoted educator well-being in medical education long before it was a hot topic. And I know he would be very, very pleased that Dr. Lotte Dyrbye is with us today to speak on caring for the caregivers of the curriculum. Kudos to the planning committee for nominating Dr. Dyrbye to speak on this topic. Dr. Lotte Dyrbye is a professor of internal medicine at the University of Colorado School of Medicine and was recruited there to be the Senior Associate Dean of Faculty and Chief Wellbeing Officer after a distinguished career at the Mayo Clinic. Her numerous national and multi-institutional studies, randomized clinical trials, and innovation reports have produced more than 130 scholarly articles, abstracts, and other written publications related to physician well-being. Dr. Dyrbye has received 11 competitive research grants to support her work, and she co-developed the widely used Well-Being Index and an interactive web-based tool, including a validated instrument for self-assessment, access to tailored resources, and organization-level reports with comparisons to national norms, all very, very useful tools in this space. She's a member of the National Academy of Medicine Action Collaborative on Clinician Wellbeing and Resilience, and co-authored the National Academy's consensus report, Taking Action Against Burnout, a Systems Approach to Professional Wellbeing, which was released in fall of 2019. The report calls upon leaders in healthcare organizations to prioritize major improvements in clinical work environments to prevent and mitigate clinician burnout and foster professional well-being. It's taken some years for the dissemination of that message to occur across institutions, and we're just so happy to see that wave continuing to mature through medical education in the US. Dr. Dyrbye is frequently asked to give presentations both nationally and internationally. She is a thought leader, researcher, and innovator in physician burnout and engagement, and we are very pleased that she accepted our invitation to be here for the Richard C. Vari Endowed Lecture. Please join me in welcoming Dr. Dyrbye to the podium.
Thank you very much. All right, well, thanks for coming out. Spend your lunch with me, with all of us here together. Let's see, oops, can I get the slides, please? There we go. So I do have a disclosure. I'm actually not going to be talking about the well-being index today, but anyways, just to put that out there since it's a CME talk. So the other thing I'd just like to do as we get started is to really just ground all of us in a common definition for burnout. I think many of us kind of have our own definition or think about it a little bit differently, but I tend to lean on the World Health Organization definition, right? That's a phenomenon that happens due to chronic levels of stress. It's unmitigated. It's not a mental health diagnosis. It is really an occupational phenomenon. And I think we're all aware, since you came today, that there's a high prevalence of burnout in physicians, obviously in all of us as clinician educators, in other members of the medical school. We know that physicians are more likely to have burnout than other US workers, even after we control for work hours and a variety of other factors. We're really hopeful because, as you can see from the slide, the prevalence of burnout, which obviously really peaked during the COVID-19 pandemic, has gone back down to at least 2017 rates. So sort of indicating that our community as a whole is starting to recover from all of that stress and increased workload that correlated with the COVID-19 pandemic. Of course, we all sort of experience burnout at different stages of our careers. There's lots of different factors that drive it. We do see from our research that, it doesn't really matter what you do for a living, the more work hours you sort of log, the higher your risk of burnout. And kind of in contrary to commonly held belief that it's sort of a old person's phenomenon, we see that burnout is actually much more common in our younger healthcare workers. The gender data is actually really complicated. You'll see lots of stories that women have higher rates of burnout. But actually, if you start to control for things like specialty and practice setting and harassment in the work environment, those gender differences go away. So it's not that women are somehow more vulnerable to work stress. We see big differences also by academic versus private practice. We see big differences by specialty. Here, just a slide that you may not be able to read very well, but it shows the differences in the prevalence of burnout by specialty, really going back to 2011, then 2014, 17, 20, 21, and 23. Pretty often emergency medicine is at the top of the list. And even after you control for other factors such as work hours, you see kind of the front line of care, really, general internal medicine, family medicine, having a higher prevalence of burnout relative to other internal medicine subspecialties. So there are some nuances kind of in the differences of how we're experiencing work stress related to just the types of work that we do. So why should we focus today on educator well-being, right? Like, why does educator well-being matter? Well, that's one of the things that we're going to talk about today. These are the objectives. Any good educator has, the learning objectives for our time together today. So I hope really to be able to tell the story of why it matters, and also importantly to talk about, how do we think about our strategy to approach it, to mitigate our risk of burnout because of its negative implications. So just raise your hand if you have ever in your entire professional career maybe felt a little bit exhausted or a little bit burnt out, a little bit stressed out, a little bit callous maybe toward people around you, right? Like, it is really a pretty common, ubiquitous experience. It may come and go during our long career, but I think all of us, honestly, have experienced some degree of burnout at some time or another in our career. And I think we can think about our stressors as clinician educators. They're a little bit different than our stressors as general internists, for example, or as OB-gynecologists, right? We have some different and unique stressors. And even as an educator, they can vary by if we're a clinician educator kind of in the clinic, or we're mostly a didactic sort of or small group teacher, or we're an administrative education leader, right? Like, our stressors are a little bit different, as is what fills our cup, right? So sort of our sources of fulfillment are also a little bit different. This is just me sort of randomly thinking about, okay, if I wear my teacher in the clinic hat, what's stressing me out? If I wear my didactic educator hat, what's stressing me out? If I wear my hat that I've had before, being an education leader for a curriculum, what has stressed me out? And I hope that you'll find some things on the list that kind of resonate with you as both things that might be stressing you out, as well as the why you do the work, right? Like, what is fulfilling about it? Why do you take on this extra role as an educator? So just take a second here, just talk to the person next to you. This is the interactive part of the talk. And just share a little bit about what are some of your biggest sources of stress, but also what are some of the things that are really filling your cup as an educator. So I'm just going to give you like 30 seconds. Just share a little bit with each other. All right, thank you. So anybody kind of comfortable just screaming out what's stressing you out in your role as an educator? What are sources of stress? Stress-free here in Virginia. Deadlines, right? Deadlines. Yeah. What's filling your cup? Why do you choose to educate? Coworkers, so sort of the team, the people that you get to hang out with, right? The collegiality piece. Yeah, great. So we do this work, right? It stresses us out. It sort of fills our cup at the same time, which is why we choose to be here. So why does our well-being matter? Well, it turns out how we show up, our well-being impacts the learning environment, right? Which impacts ultimately the learner's experience, which impacts the learner's outcomes, right? And that's sort of the story that I'm going to tell today, the first part of the story. And if we think about, educator well-being in general, most of this literature here is kind of in the K through 12 space, but there's been lots of systematic reviews that sort of show educator well-being matters in important ways. It matters lots to the student's experience, to the student's outcomes. It matters a lot to whether or not you can hold on to your workforce. It matters to the culture. And we see this really ring true regardless of the lens that we look at it through. That how educators show up is so important to the experience of the learners, the reason that we're here. When we had a Department of Education, they were in the game too. There's a great white paper that talks also about, their perspective on why educator well-being should be paid attention to, why it's important, how it correlates with all the things that we care very deeply about. And if you start to look at the medical education literature, there is also very similar data about how educator well-being impacts the students, the very reason that we're here. This is a study that they actually did use the well-being index, but what they did is they looked at clerkship rotation scores. They looked at how the students had rated teachers and their effectiveness scores. And then they looked at how the teachers themselves were answering the well-being index, sort of a validated measure of their distress. And they could look at it by departments because the well-being index was anonymous, right? But they could sort of look at how are the clerkship scores, right? How is the rating of the faculty? How does that relate to the well-being of the faculty in various departments, divisions, sections? And they found, of course, that it was very strongly correlated, right? Where you had really stressed out, burnt out, unhappy docs, you had a negative work environment, right? The clerkship ratings were lower, the teaching faculty rating forms were lower. And that makes sense to me because probably a couple of decades ago, I did a study with the clerkship directors of internal medicine. And I simply asked them about their level of burnout using a validated instrument. And then I started to just ask them, do they care about their students? How stressful is it working directly with the students? And sort of as you expect, right? You see sort of what we'll just call suboptimal attitudes amongst the program directors in internal medicine who were really burnt out, right? That obviously it impacts how they're showing up for the students. And we also see, no big surprise, that in our residency programs, when our program directors are burnt out, they are much more likely to stop being program directors. And that kind of turnover is not good for our learners, right? It's not good for the learning environment. We want to keep our program directors. We want to make sure they have sustainable work because them turning over is not good for our learners. And it's, of course, no surprise that burnt out program directors, step away from being program directors. We see the same thing for us as physicians. When we are burnt out, we're twice as likely to leave our current employer. Not thinking about it, not talking about it, but when we look at survey data and link it to HR data, we actually see that the burnt out docs leave, right? If we're not leaving, what we're doing is we're cutting back on the time that we're spending taking care of patients. So we see that as burnout worsens. It correlates very strongly with docs reducing the time that they're taking care of patients. And if you take the data that we had at Mayo Clinic and extrapolate that nationally, that basically means you have 3 graduating classes of medical students every year not taking care of patients, not being available to be clinical preceptors, not being available to supervise residents in clinic, right? So it has enormous implication to educators. The other thing that we have learned is how leaders show up impacts their leadership behaviors, right? So a leader's well-being is an independent predictor of how the people who they're leading perceive them in terms of their leadership capabilities, okay? Now you can say, well, why is that important? Well, it's important because how I rate my immediate physician supervisor is an independent predictor of my well-being. We see the same thing in residents, okay? How residents rate their program director leadership team, that's an independent predictor of their burnout, their satisfaction with their sponsoring organization, and their satisfaction with their program. Okay, so that how the leaders are doing their well-being is a really impactful piece of the puzzle for us to think about. This is just the data in physicians showing that it predicts things in the future, right? So again, how I rate my immediate supervisor predicts my well-being 2 years later. So this really does matter. And if we think about it really from us as clinicians, right? One of the places that we obviously teach our learners is in the clinical space, whether we're a resident educator or we're a medical student educator. And when we are burnt out, we are less likely to practice cost-conscious care. When we are burnt out, we are more likely to have unprofessional behaviors in the clinical work environment. Our learners are seeing that. We are less likely to report impaired colleagues, to step up to our professional values. We are also much more likely to make medical errors. Surgeons who are burnt out are twice as likely to be involved in medical malpractice litigation suit. The level of burnout of your nurses in your hospital is an independent predictor of hospital-associated infections. The level of burnout in the doctors in the ICU and the nurses in the ICU is an independent predictor of patient mortality. All of that is happening in the learning environment, right? All of that, the residents, the medical students are seeing and are experiencing. And it goes, I think, really one step further in how we show up in the work environment. So this is a longitudinal study from a single institution. And they found that at the end of the 3rd year of clerkship, what predicted depressive symptoms in these medical students was not only how depressed they were starting the 3rd year, obviously, but it was faculty role modeling, right? And it was how we were perceived in terms of how we were treating them, right? Those were independent predictors of depression in the medical students. We've seen that subsequently. This is a big national study that I conducted where we looked at medical student depressive symptoms at the year 4 time point. And we saw what predicted that was whether or not they indicated they had been mistreated in year 1 of medical school, whether or not they had seen negative role modeling by us as clinician educators, and whether or not they felt that there was a negative racial climate. And that persisted, didn't matter what the race or ethnicity was of the students. And this was after controlling for a large number of other factors that you can do one of these fancy multivariates. Here's another study of over 14,000 medical students. We see that how their reports of mistreatment during the 2nd year, but also their reports of the emotional climate, right? And the emotional climate sort of has to do with this sense of achievement, valuing oneself, confidence in education abilities. But the third thing that also impacted their burnout, their career regret, and their sense of empathy was their interactions with us as teaching faculty. Okay, it's a very powerful predictor of the student's well-being. Let's just take it into GME. We see as residents in the 2nd year report unfair treatment or negative interpersonal experiences with us at work, that's an independent predictor of their well-being a year later. Okay. And of course, we know this study that was published in the New England Journal of Medicine, which showed that the US surgical residents were experiencing mistreatment, and it was mostly done by us. And when they experienced this sort of mistreatment, it led not only to burnout, but also to suicidal ideation. But it's not just the extremes of behavior, right? We know when we're burnt out, we're more likely to behave unprofessionally. It makes total sense, right? You're stressed out, you're at your tipping point, and that negatively impacts the learning environment. But there's also more subtle things, right, in the ways that we show up at work. So these are just some of the behaviors that are associated with burnout on big multivariate analysis in resident studies. So, being a role model on self-care, right? When we do that, the residents are more well, right? When we show the limitations of our knowledge, like, oh, that's a really good question, we should go look that up. Being willing to be vulnerable in the moment, that actually is associated with resident well-being, right? So all of these behaviors, managing time well, being respectful of others, right? All ways in which we show up that impacts the experience of the residents. But here are some others, right? Just being accessible, being trustworthy, caring about the residents as people. All of those behaviors are very much associated with resident well-being. And not only are these behaviors, the professional behaviors, how we interact with residents, but their level of satisfaction with the degree of autonomy we provide the residents, how we show up as leaders, that's also associated with residents' perceptions of social support. And that piece is really important actually for all of us. If you think about social support, the single most important predictor of whether or not a soldier who's experienced a traumatic event in the field develops PTSD is actually their perception of social support. We see social support over and over and over again in the literature. Whether you're looking at nurses, you're looking at physicians, you're looking at medical students, you're looking at residents, it's an incredibly protective factor. So the more we can work on developing social support at work and with our learners, the better off we're going to be. The intern study, which comes out of Michigan, which is a big national study, they're also seeing consistently that how good we are providing feedback is an independent predictor of residents' depression. And they have some good news in their study in that the residents in the intern study over the years have become more and more favorable about our feedback skills, suggesting that all our efforts from teaching academies and things like that for us to get better at giving feedback is making a difference. The other thing that's been discussed is, does our burnout, is it contagious? Right? If we as faculty are burnt out, how is that affecting the resident burnout? How is it affecting the medical student burnout? Because what we see in our studies is that the subspecialists with the highest rates of burnout in practicing physicians, they're the same subspecialties with the highest risk of burnout when we look at residency programs. Now we can all sit here and go, is it contagion? Is it because the residents, the faculty who are burnt out are just mistreating and being bullies and, you know, not being good educators, and that's negatively impacting the work environment so the residents are more burnt out? Or is it that they're all working in the same crazy system where the workload is too high, the systems are too inefficient, so everybody's getting burnt out? We don't really know the answer to that. It's maybe all three, right? But it's nevertheless another reason for us to care about educator well-being and why we need to do something about it. Because ultimately it's mission critical, right? We think about the mission, if we think about why we're here, educator well-being has got to be a key part of that strategy so that we can live true to our mission. So now to the more interesting part, right? They're like, okay, we know this, right? We know burnout's a big deal. We know educator burnout really matters to our learners. It threatens all the things that we care about, whether we're looking at it through patient care lens, learner experience lens. But like, what the heck are we going to do about it, right? And it's a wicked problem. I think we talked about this, you know, sort of earlier today in my visits, right? Like, it's not caused by a single thing. There's not a simple solution, right? It's complicated. And of course, the elephant in the room, I think it's an elephant, it's kind of not, doesn't project that well, you know, is the clinical practice environment, right? For many of us, it's the clinical practice environment, which is really contributing mostly to our distress, probably more so than, you know, our deadlines or other things as our educator hat. So how do we sort of think about that, right? Our learners are obviously in the same work environment, you know, so how do we think about really improving their learning environment, our work environment, our collective experience? Hello. Did I turn this off now? Oh, there it goes. Sorry. We talked about this. Okay. So here's an example of a strategy, right? So this is the Stanford strategy that's modeled at many healthcare organizations across the country. And you have some of the pieces here, right? So this is really about local unit action. This is about rheumatology action. This is about OB-gynecology action. This is about general internal medicine action, right? Where they have this process of we measure what we care enough about to try to change, right? They have a network of well-being leaders in all the different departments who share the survey results and who really talk to their colleagues about what are the things that are in our sphere of control. They do action planning. They pick a couple things with the input of their chair to try to work on in the department. They escalate things that are outside the department's control. They partner closely with quality improvement leaders within their department. And they work on things that range from culture to work efficiency to really faculty development and support. And they've shown that this intentional process, maybe it's just taking one pebble out of the shoe at a time, but this intentional process makes a measurable difference in the well-being of the faculty. So this is one model that's being really commonly used across the country, and it's making a difference. We do the same thing at University of Colorado, and we have a network of our well-being leaders, and they work on things that are really in their sphere of control. They are very happy to share all the things with me that they think are in my sphere of control. I wish my sphere of control was as big as I thought it was, you know, but, you know, working on it. So, you know, things that are in my sphere of influence, maybe, right? And then there's kind of these things that are my, you know, that we're all sort of concerned about, but can't directly impact potentially in our everyday lives. And you can see here that the departments have a variety of initiatives sort of across the domains that you see on the slide. But of course, it's not just about the departments and not just about the well-being leaders. It's also about the School of Medicine. You know, what are the types of things that we can do to improve the work experience of our clinicians? And we always have a variety of different things, some successful, some not, some short-term, some long-term projects that are in place as well. And you can read more about that on the website if you'd like. And I think that this is one of the roles of us as an educator, right, is to be that change agent. We know that a lot of the stressors from our clinician educators come from the clinical work environment. What we need to do is to stop othering and to take on the piece that we can take on to improve our work environment. So that might be filling out the survey. It might be, bringing up ideas for what might work better. It might be being willing to pilot something new, right? But that optimism is something that I think our learners deserve. And studies have actually shown that when we engage in local work improvement efforts, our well-being actually does improve, right? It gives us community, we learn something, we feel agency, it gives us a sense of meaning, so it's an important piece of the puzzle. The AMA has Change Med Ed that you might have heard about, and they had this publication, which I thought was actually quite good, really focused on educator well-being. And they proposed kind of this framework for how to think about improving educator well-being. One of the things they talked about, right, is symbolic, right? So are we recognizing and rewarding our clinician educators? They talked a lot about sort of the political pieces. Are our voices heard, right, within leadership decision-making? Human resources, they sort of talked about providing professional development, community of practice, coaching. All these things have become quite popular. And then importantly, they also talked about structural things. One of the things that I've tackled at University of Colorado is our promotion system within the academic rank track. When I came, we had a regular track. And then what does that mean? Everybody else who's not in that track is somehow irregular, right? Or less worthy. It does actually, it's very hard to change the names of tracks in academic medical centers, but we did succeed. The other thing that we were able to do is remove the clock. We have a very traditional system, up and out. Once you get to assistant professor, you have 8 years to get to associate, or you can find your way out. And we were able to get rid of that clock really for our clinician educators. So thinking about how do we value everybody, right? In our very diverse phenotypes across an academic medical center. So those are just some examples. The academies like you have here are another great venue, right? If you think about it, academies are for recognition of our excellent clinician educators, but they're also for building community and social support, right? Which we've heard about is important. And they're important for skill building, right? We all know that becoming a doctor doesn't make us a great educator, right? That takes intention. We have to learn how to give great feedback. We have to learn how to cultivate a positive working environment, right? We have to sort of learn sometimes some of these things that we're uncomfortable with, like role modeling the limits of our knowledge in front of our learners, right? Important strategies. And academies can fill a big role there. The thing that I've been challenged with is how do I get my chronic, burnt out, overloaded faculty to engage in faculty development, right? Like, hello, Lotte, how do you do that? Nobody has any noon hours. I'm all impressed that you guys came today, right? Nobody wants to stay late or come early or forbid, have something on the weekend, right? So how do you sort of make that work? One of the things that we've been playing around with for the last, 5 or so years is really a twofold strategy. One is about micro-learning, right? So we push out, 5-minute videos that have 5 very practical tips from someone who is often highly regarded as one of the best educators or one of the best clinicians. And we push these videos out. We encourage education committees, departments to show the videos at the beginning of meetings when everybody's gathering their lunch and just getting situated. And we have an incredibly high uptake on these videos, right? We can really see that people are watching them while they're waiting for the soccer game to start or walking to their car or wherever else they may be sitting. We actually get good uptake. And then sometimes we can link to deeper dives, right? Like we hook up, like, oh, maybe I do want to learn more about that, right? So we connect it with something that's longer that maybe has a bigger impact. Our other big strategy in the faculty development space is really what I call an instead of. So everybody has faculty meetings, right? As a general internist, it's on Thursdays, it's at 7:30 until 8:30, and no thank you, I really do not need to hear about cellulitis again, right? Like we have all the same sort of topics. They're important topics. But what about if once a quarter or twice a year, or heck, even just once a year, one of the 7:30 in the morning CME conferences in general internal medicine was instead about how to give more effective feedback? right? Like we are an academic medical center, right? We have learners, you know, so that's an instead of concept. So, okay, how do you make that work across the health enterprise, right? You've got all these regional places, right? Your learners are going to lots of different places. You know, you have one little office of faculty development. How do you make that work? Well, what we found work is that we basically make a workshop for like 50 minutes or 40 minutes centrally at the level of the school and the dean's office, right? We get some instructional designers to help us if we can afford it, you know, and we make like how to give great feedback, how to improve narrative evaluations, right? Various topics. We give the slides, they're editable. We give speaker notes, we give activities, we give evaluation forms. It's like, here's the whole package, right? Now go embed this in an existing faculty meeting. Now there's always a couple of departments that never seem to have educators, right, to deliver the content. Well, then we use our wonderful academy and we say we have a speaking bureau. You know, we have great educators who are willing to go to department of, let's just pick on neurosurgery for fun, right? Who are willing to deliver this content to your faculty during an existing meeting. So that's just one way that we found that we can get educator development into the lives of really busy faculty. Because we all want to teach like Ted. Who's like really looking forward to the second season? He's like my leadership idol. He's so great. The other thing that we learned before, right, is that leadership skills really matter, right? We've shown that it impacts, you know, the well-being of our residents. These are not tough leadership behaviors. These are leadership behaviors that each one of us can do today. This is all about how we can show up in our work environment, how we can show up for our learners. And certainly this can be incorporated into any and all leadership development programs, right, across an enterprise. You don't have to go to some 2-week course in Harvard, right? This is something that we can all work on today. There are other pieces. So if you think about, you know, physician turnover that happens due to burnout, and you think about people reducing their clinical FTE due to burnout, right? That's costing you $7,600 per physician per year. Just thinking about that one little piece. We've shown that while we're working hard on the work environment, right, providing a resource to external credentialed coaching is actually an effective strategy for improving retention and reducing burnout in our clinicians. Now you can say external credentialed professional physician coaching is expensive. It sounds expensive, right? This was 3.5 hours over 6 months. This does not cost you $7,600. Okay, so here's another kind of evidence approach that we can take to kind of a little something we can do for all of us as faculty while we do the really hard stuff. Change is slow, we talked about earlier today, right? While we do the really hard stuff to help improve the workload. The other thing that's been tested in Colorado is web-based coaching. So this model is from Better Together, which has been really shown to be effective in randomized control studies, particularly for residents. It does appeal more, for whatever reason, to female residents, but it has really good outcome data. We did a pilot of Better Together in faculty. We, in all honesty, had a high dropout rate, but even with that, the people who did stay in, they gained. And I think the point is there that different things are going to appeal to different people, right? So the more we can put different options in the toolbox, right, the more likely we're going to be able to give some help to our clinician educators. The other thing that we have found, again, go back to social support, is that bringing people together for conversations can be really helpful. So these are commensality groups, and we did a couple of RCTs at Mayo on this. The first commensality group, we brought physicians together with a trained facilitator on company time. So this would be from like 12 to 1:30. People got out of their clinical responsibilities for a short period of time. We had a topic for them to talk about, like how do you deal with medical error? How do you minimize, you know, work-home conflicts? A variety of kind of strategies to share tips. And we found that this model was really effective. It reduced burnout, it improved retention markers, it was great. So we tried it off to the Board of Governors and we're like, hey, we have this great thing. Everybody needs to go to group, it needs to be facilitated, and you can be taken out of the clinical practice for half an hour. Yeah, Okay, you're all just smiling. You can imagine how well that went with board of governors, right? So we tried again. We said, okay, how about if docs just self-organize into groups? They meet after hours or outside of work hours. We don't have a trained facilitator. We give them a topic to talk about, which they may or may not talk about. And then we do the randomized control study, and we show that this works. Okay, so this is commensality groups, or they're called compass groups. And at Mayo Clinic, at least, it continues over a multi-state region. There is about 1,500 clinicians as well as scientists who participate in commensality groups. What do? They build social support, right? They help people sort of get through it all. And this is a piece where I think our culture really needs to shift, right? And we need to role model this for our learners and really for ourselves. That we need to remember to put on our own oxygen mask, right? Before we can really help others. And this piece around self-care is actually really important. Now, it's not that because burnout is because of some resiliency deficiency, right? We actually have higher levels of resilience than other US workers. And Muffin Mondays are not going to solve burnout, right? But nonetheless, we each have a personal responsibility, right? For doing the best that we can to take care of ourselves, to role model that behavior, and to show up, for our learners and for our patients. So the last piece that I just wanted to cover before I open it up to questions is this idea about how do we, in addition to taking care of ourselves, how do we really incorporate these sort of principles of well-being into our curriculum, right? Sort of into how we think about educational design. Well, I have a few thoughts on this as well. One piece is around grading schema. Do you have pass-fail here? What's your grading schema in the medical school? Pass-fail, 5-point grading scheme. What do you have? You have pass-fail in the first 2 years? Right. So that's an evidence-based approach, right? We know that schools that have pass-fail in at least the first 2 years, they have not only better student well-being, but they have better cohesion. I mean, what are we trying to teach these students? We're trying to teach them to work together, right? And if you put them in a pass-fail curriculum, they have better working togetherness, right? Which is some of the things that we're trying to do. Before the STEP exam went to pass-fail, we were able to see that there wasn't a negative impact on their Step 1 score if we went to pass-fail in the first 2 years. We've also been able to show that their clerkship grades are not any worse if they have pass-fail in the first couple years. So that is sort of a key evidence-based strategy. Another one is really to use, criterion-based grading, right? So if you're going to have kind of a high pass, honors, pass, whatever system in your clerkships, that it's not limited to the top 10% or the top 5%, right? It's based on benchmarks. It's based on competencies, right? We really think about that from our evaluation framework. It also turns out in our studies of medical students that it doesn't actually matter how many hours they work. It doesn't matter if they're in the ICU or in the outpatient practice. It doesn't matter how many patients we're asking them to round on. None of those things predicts their well-being. What predicts their well-being in the third year is like whether or not we're able to prioritize their education, whether or not we're giving them good feedback, whether or not the rotations are well organized and they are told where to show up, right? Those things impact their well-being. It's actually not how hard we're asking them to work or how much call we're asking them to take. So big national multi-institutional studies on that. And then the social support piece that I think we've talked about. And it's not just one thing, right? It's not just one thing for me as an internist. It's not just one thing for you, whatever capacity you have. It's the same thing for our students. So this is a classic study actually from my friend Stuart Slavin. He did a bunch of stuff in the first 2 years of the curriculum. He has no idea what worked, right? But what he had good intention, and he measured the outcomes, and he saw improvement in the student well-being for the first few years. He introduced learning communities. He fixed some things in anatomy. He did a variety of different things. And I'm just proud of academic medicine for publishing it because the methods are kind of a mess, right? But he was able to show that with intention and with incremental action, you can make a difference. This is a study out of Colorado where, traditionally the residents have had 4 weeks of inpatient, and 1 week of ambulatory. And they repeated that over and over and over again. And then they sort of realized, like, most medicine is practiced in the outpatient setting. Maybe we should change this, right? So then they went to a model of 4 weeks in the inpatient setting, 4 weeks in the outpatient setting, and they were able to see actually also improvements in burnout in those with that curricular change in the residents. But this kind of stuff is tricky, right? Because here's another study of us attendings. And they did a trial where they looked at, what if we had an attending on service for 4 weeks versus attending on service for 2 weeks? And as you can imagine, the 2-week rotation was better for the attendings, but maybe not better for the residents, right? Because they are losing continuity of relationship with their supervisor, right? Changing expectations, having to get the new attending up to speed on all the patients, right? So, there appeared to be a negative impact on teaching. So it's like, wow, how do we sort of make it better for everybody? And I think that's a hard thing to figure out. I think here are some of the other kind of general principles to think about. There's been studies that have shown that we assign the students more reading than they can possibly read. Right? This concept of curriculum-megaly, right? Like, students have to learn everything that I had to learn in medical school, plus everything else that's been, introduced since then. There's talks about, well, the medical students need to add value. What can they do for us in the in the health system? How can they add value? And I'm like, really? They're here to learn how to take care of patients, right? So, there's lots of tensions, I think, in the environment currently about, how do we really do this and do this well? How do we think about incentivizing and rewarding wellness-centered leadership behaviors so that we get more of those out in our environment, right? I really think that there's a variety of strategies to think about in that domain. Similarly, also just thinking about, our pedagogy, right, about active learning, about all the things that all of us know a lot about. This is also a really important piece, obviously, to optimizing the experience for our students. And I can't, really end this talk without just recognizing and circling back to this issue of mistreatment, right? It's not obviously all about whether or not it's happening. It's being perceived that it's happening. And we know from our research that it often also comes from patients, families, and visitors, and doesn't always come from the members of the healthcare team. So it's important that we just continue to work on our efforts to address the issues of mistreatment that are happening in the learning environment. And of course, this can take real partnership with our health systems, right? I remember the first time as an attending that I had a patient say a racist thing toward one of the team members. And frankly, I admit this, like, as part of my recovery therapy, I think, like, I keep admitting this to audiences, that I didn't say the right thing. I didn't actually do anything. I was just so floored by, like, what had just happened. I had absolutely no training to know how to respond in the moment to this horrific event, right? And I think that's where we have real opportunities, right? And I think things are shifting now. People are doing bystander, upstander training, right? But you have to know that your hospital has your back if you're going to tell the patient that is not aligned with our values, right? If you're going to try in the moment to sort of fix that and help and stand up for the learner, right? This is important not only from just an employment law perspective, but it's important for our moral grounds, right? That we all figure out how to do this, how to shift the culture, how to say that is not tolerated in our work environment. So just another important piece. And circling back to this issue of self-care, we are powerful role models for our learners, right? And all too often our learners are really reluctant to seek care for their mental health concerns. And they're more reluctant to seek care than basically similarly aged people in the US population. And to me, that just seems so fundamentally wrong, right? So this is, I think, really where we have an opportunity to tell our story or to share the stories of others that have been out in the press, right? These sorts of storytelling about Daryl Kirsch's experience, for example, can really help the medical students see, oh, I can get help and still be super successful, right? Being able to do this locally makes a bigger impact than actually pointing to people that they don't know. But being able to sort of share these stories of recovery can be enormously helpful in getting the students to sort of say, okay, I need some help, I'm going to get some help. and is going to help me be the person that I want to be. And of course, with all these efforts, we have to measure what we care enough about to try to change, right? And I know you're using the AMA organizational biopsy for your faculty. And obviously, we have the AAMC Y2Q, we have the AAMC graduation questionnaire. You know, this is an important piece of the puzzle, right? Is so measuring it so that we know if we're making progress. If you want to learn more, I direct you to the chapter on the learning environment in that National Academy of Medicine Consensus Study report. It's available for free online, or you can, get some publication. It's quite a book, but it really summarizes a lot about what we knew before the pandemic, about learner experience, about all the potential avenues for making improvement. So this is just my last slide. I just want to, well-being is not an add-on, right? It's integral. It's critically important to the things that we do, what we care about. Educator thriving is mission critical to the organization. And there are some evidence-informed steps we can take to make improvements. So with that, I thank you very much for your attention and happy to take any questions.
You covered so much ground, and it's just, there's so many things that are relatable to what we were thinking about in the medical school system. I don't want to call on anyone, but I know there must be comments and perspectives to share. Yes.
Thank you. That was wonderful. Thank you so much. That was a wonderful talk. I really enjoyed it. I had a question. You mentioned that younger physicians are more risk at burnout. What is the reason for that? Because it worries me. When I was young, 20 years back, I'm still young. We never thought about that, talked about that, but I have seen that. What can you do to prevent that? And what is the reason for that? That disturbs me, that our younger people are suffering more.
Yeah, and we see it. We see it we've done studies in pharmacists, dentists, nurses, advanced practice professionals, large studies of surgeons, of neurologists. We still see it. Now, there's a possibility that it's survivor bias, right? Because these are cross-sectional studies, and that, the people who burnt out have sort of laughed, and that's kind of why we're seeing this. Or it's the reality that, being a physician today is different than being a physician 20, 30 years ago, right? There are, frankly, many more, dual working couples, right? Patients are no longer admitted for DVT. Right? The complexity of care has gone berserk. In my personal experience, I would say patients and families' behaviors have changed enormously during my career in the work environment. We all continue to struggle, I think, post-pandemic with things like staffing, right? And our ability to deal with it is maybe a little bit different, than our younger colleagues. So I think that there's a variety of things. What I don't think it's that we're letting the wrong people in. I don't think that it's the weaker generation. I think that the work experience is just really different now than it was 20 or 30 years ago. And we have to figure out how to help them, right? We have to role model the right behaviors. We have to help people assimilate into their jobs. We have to step up and be the mentor. But it is worrisome because it predicts, really loss of the workforce. And that's the last thing that we can really, absorb at this point.
What I sort of hear you saying is we need to do what we do for our students, the same thing we do with our patients. Meet them where they are and come to them with compassion and support. And that way we're modeling what we expect them to do with their patients in the future. They're people too, and they become part of that existing community. I see a lot of really great educators who are here today, some working mostly in the preclinical phases, others mostly in a clinical setting, and some in both across the whole continuum. Any additional comments or questions from those of you who are listening to those perspectives? Rick, it's fine. Well, we'll save some time after if folks want to come down and ask one-on-one questions. But for now, Dr. Worker, please join me. Dr. Dyrbye, thank you so much for being here. In addition to our Area Endowment Honorarium. We have the certificate for you. Memory for being here with the title of your talk.
Thank you.
And we really appreciate all the great work that you do and sharing it with us today.
Thank you very much.